Okay, so I'm going to tell you a good news story about joint working, okay? And just before I start, this is, I suppose, a bit of evidence this is good news. So just last night we found out that the Don't Wait to Anti-Coagulate project, which is our joint working piece of work, won an award at the PMEA Awards, which I understand is a big deal, apparently. And so the quote that came through attached to the award was at the bottom there. So, and I didn't write this. Okay, this is a fantastic initiative with a complex group of stakeholders. It encompassed the identification of clinical need, thorough evaluation, a pilot study which proved the concept, and true NHS industry collaboration. The resulting patient outcomes were extremely impressive, and the project has been taken up nationally by the NHS, which speaks volumes.
Well done.
That's the end of my talk, so there you go, that's the end of it. All right, okay. So, so my name's Steve Ray. I'm a Quality Improvement Implementation Lead in the West of England Academic Health Science Network. So for those of you who may not have come across AHSNs in the past, there are 15 of them across the country. One of the core licence objectives of AHSNs is about improving capability around quality improvement. It's about joining up tech companies, so the health technology companies, with the NHS, so they can work with each other on improving innovation in that area. But also it's about partnering with industry, so partnering with pharma companies, other industry partners as well. So what I'm going to do is give you a run through of the structure of the project. I'm going to give you an idea about what the collaboration approach that we took with our partners. And also I'm going to give you opportunity to ask lots of questions. So because this is the graveyard shift after lunch, I want every one of you to think of at least one question, because I'm going to be picking 3 of you at random afterwards to ask, so pay attention. Okay, so the aims and objectives of the Don't Wait to Anti-Coagulate project was very much about working with our primary care colleagues across the West of England to improve essentially compliance and adherence to the CG180, the NICE guidance. And it was about with the eventual outcome of reducing the risk of stroke. But also it was about increasing clinical confidence in making those decisions, but equally about working with patients to promote shared decision making about that particular decision. It was about designing and testing innovative approaches to service delivery and pathways. And also, most importantly, it wasn't just about the West of England. AHSNs, there are 15 of them across the country, so the idea for each of us is to design and test things locally, which then can then be picked up and spread across England through our AHSN network. And personally speaking, one of the things I found most exciting about this project was about embedding quality improvement capability. Quality improvement is something that's having a great deal of traction in the NHS generally. So if we look at things like the NHS 5-year forward view, about 4 or 5 of the 10 high impact actions rely on a knowledge of improvement science and quality improvement capability. So we built it into this project from the outset, and that was essentially the sustainability model that would support it going forward. From the outset, it was around collaboration. So it wasn't just something that was a strategy or a plan. This was a foundational commitment from us as an academic health science network to all of our partners that we would work with them, obviously patients being first and foremost, but also clinicians, commissioners, also industry colleagues as well. And I say it was very much a lived experience for all of us. So it wasn't a situation where at the start of the project we could say, this is where we will be in 18 months' time. It was, this is the achievement we want to achieve, this is where we want to get to in terms of achievement. How we get there, that rocky road, is something we'll experience as we go forward. So I think one of the earlier speakers talked about having a set plan in advance. I think the reality, when you're looking at innovation, that's quite a difficult thing to do. So in terms of the programme structure overall, so phase 1 was our innovate and test. So the first step was for us to understand what were the key enablers and the key barriers to anticoagulation in primary care. What was it that stopped it happening? It was known about, the evidence was clear, but there was something that was getting in the way. And so what we did was we spent quite a lot of time talking to patients. We did some local focus groups, we went out to visit patients in their homes, and we talked to them what was it that stops this? And also, importantly, we talked to clinicians. We said, what is it that stops you in when you're having that conversation with the patient? What makes it difficult to potentially optimise management of atrial fibrillation and the proper management of that? And so the key things that came back, so when we think about from patients, it was about not really understanding in that 10-minute consultation what they were being asked to do. What was the solution? And we know, obviously, that in terms of shared decision making, it should be something where it's a joint decision, with the patient obviously being foremost in that. And from a clinical point of view, it was essentially clinicians, or this group of clinicians, didn't understand what it was they were asked to do. They didn't really understand the evidence base. They were concerned about things like bleed risk. You know, what were the issues that the patient might deal with? And so essentially, it was easier to be able to say, well, we'll just carry on with we'll keep you on antiplatelet therapy, for example. So phase one was very much about working with those key stakeholders and designing a series of models, different approaches that we could use in primary care that might shift that patient's care in the right direction. And so what we did with these innovator practices, these 11 practices, we said, okay, we want you to select one of these models, try it, we'll observe you for 12 weeks, we'll evaluate it and see what happened, see what worked. So in phase two, then it was about saying, okay, we've tested it in a small scale, we've got some evidence about which model might have the greatest impact. Let's pick it up and spread it at scale. Let's try it across. In this case, it was in Gloucestershire. We aimed for 83 practices. We actually had, it was 51 actually, the practice that we completed with. And then phase three is where the wider AHSN network becomes very important, because very much about we take what we've learnt locally, pick it up and spread that knowledge across the whole of England. So phase one results, as I say, it was the primary aim of this was to design and test these different models and approaches. But actually, obviously, because these practices work with patients, we got some clinical results as well. So what we saw was a reduction in use of antiplatelets, a reduction in patients on no treatment at all, and an overall increase in coagulation. And so for this small group of practices, when we got our health economists to crunch the figures, it looked like what we were looking at was actually 5 to 6 strokes being prevented or avoided in that group, which is pretty powerful and really important when we were going to our second phase to be able to engage GPs and also commissioners, importantly, in undertaking this piece of work with us. And so these were the other findings from the project as well. So it's about increased awareness. It's very much about that improved decision making, shared decision making with patients, and it's really about confidence from the patients and confidence from the clinicians in how they have that conversation. So what we did was because we generated a lot of materials in phase one, probably the foremost of which was some shared decision, some patient decision aids, which could be used in clinical consultation. And what we did was we took that material and we essentially created a website, and there's a link for the website later on, called, amazingly, Don't Wait to Anti-Coagulate. But in terms of collaboration, this is where we really started to get involved with our industry colleagues. So this was open to all of our industry colleagues. So it was obviously with Bayer, with Pfizer, with Boehringer, and also with Daiichi as well. And we engaged them saying, how can we work with you? How can we work together on this? Because as an AHSN, we came with no expectations. I'm a speech therapist background, so I'd never dealt with industry in the past before. We had people in our team from education, people from the financial sector. So we just came in essentially being open-hearted, saying, how can we work with you? And I think we were talking about some issues around, problems in the delay between getting a joint working agreement outlined and then signed off. I think one of the key elements that we found was getting people involved from the very outset, from the conceptual stage, so that all those cogs could start to grind in the background. So by the time we came to the point where there were things to do, actually the governance procedures had gone through and we were ready to go. Because in AHSN, we were often seen as a bunch of pirates, really, because we wanted to move very, very quickly. Whereas obviously from an industry point of view, there are obviously more governance to go through. So phase 2 was when we was, okay, we designed it, let's now test it at scale. And we were very lucky to work with a very visionary CCG called Gloucester CCG. They'd already done quite a lot of work on trying to optimise their anticoagulation in the past. But I think what they found was they found a lot of point improvements. And so this is where the quality improvement methodology came to the fore, because I say that's the thing that would give sustainability to it going forward. And so that's really where it started to become, not just about improving anticoagulation, is how do you work with primary care colleagues to use this methodology so that when the HSN has stepped back, they could still use that methodology to sustain it going forward. More importantly, spread that same knowledge around other disease areas, for example, diabetes or respiratory. So phase 2 was essentially an audit of AF patients in those practices, and again this was working with a company called Interface Clinical Services. Because of various issues in getting data, we worked with them across all our practices, so that required quite a lot of engagement through our with our clinical colleagues, through our clinical leads. And this is really where our clinical lead came to the fore. In the project we actually had 2 of them, and they were instrumental in going out to practices, talking on behalf of the AHSN, also in industry colleagues as well, and saying, this is what the project's about. It's not about selling something to you. It's about working with you to improve the pathway and, as a result, reduce the risk of stroke for these patients. And they were going out talking to practices. They helped to get people to sign up. Practices weren't required to sign up. They volunteered. So we actually got, I think it was almost 60 practices signed up, of whom 51 completed the whole project. So again, I think that's testament to the fact that engagement seemed to have worked. We provided clinical skills training, which sort of offset some of those barriers around knowledge and confidence in prescribing. And we also, our key, if you like, our change agents were the pharmacists. So we used practice support pharmacists. We taught them quality improvement approaches. And they were the ones who worked with the GPs to make the change. What we found quite quickly was that, a couple of weeks' knowledge of quality improvement wasn't enough. So what we did was we worked, in this instance, we'd moved into a joint working agreement with Bayer. And what we had was a couple of the secondees came into our team. They worked with us as part of our project, and they were core. They gave them AHSN badges. They went out as AHSN members. They obviously weren't promotional, and they formed, along with some of our improvement leads, what we call the quality improvement support team. So they actually went out and visited practices and coached them through, okay, you've decided how you want to change things, you've decided what makes sense in your practice, how can you use quality improvement skills and science to actually make that change and to guide them through that. And I think something like, between them, they spent something like 180 hours working out in those practices to actually make that change, so pretty good. So I say 51 of the 83 practices participated and completed. When I say completed, it was essentially each practice had a 12-week window from when they had their audit, make the change, and then we re-audited at the end. Huge amount of work from practices involved. They were really engaged and motivated to make this change. And what we noticed was that there was a big reduction, something like 14% reduction in antiplatelet use. There was a big reduction, it's similar, I think about 13% in people on no treatment at all. We had a good increase in anticoagulation, of which warfarin was part of that picture. I mean, essentially, as we were working with the CCG, you said, we'll work with your formulary. Whatever you decide, that's how you want to work it, we will promote that with your practices. And so our health economic colleagues tell me, in those 51 practices in that 12-week window, something like 13 strokes had been avoided in that area, which is fantastic, given the fact that obviously we're expecting those practices to carry on that work. It's not just once and done. We would anticipate by the time they've worked through that whole backlog of patients, we're looking at something like over 40 strokes avoided. So it's a big, hopefully a big win for those patients. And then phase 3 is about, we're looking to our local CCGs in the west of England, and we get more of those involved. But then also, as I said, what we now have is a national AF community which sits above the overall the individual AHSNs. And this is about taking this project, and this is one that's being spread, I think it's 14 out of 50, it might be all of them now. AHSNs have picked this up in some form. Some have taken it whole cloth and are just going to implement it where they are. Others have just taken the principles, which is, again, about collaboration and involving people from the outset. and we've done an audit and evaluation. The evaluation for this isn't like 20,000 words. If you want it, you can have it. Okay, so to the heart of it, in terms of collaboration. So patients and public, this was absolutely foundational. From the start, I say we ran focus groups with some of our local patients. Obviously, it was only representative of a small number, but they essentially informed the creation of our decision aids, the materials, what was acceptable, what wasn't. We had 2 public representatives as core members in our steering group. So they were there from the outset. And our steering group was everybody. We had commissioners, we had patients, we had industry members, we had strategic clinical network members there as well. So essentially anyone that had an interest in the project, it was open house. You could come in and be a core member of that steering group and guide it. And I think what was really interesting as well was in the early days of that steering group, there was a lot of storming by any team of people, and there's a lot of challenge to our industry colleagues about, well, what are you getting out of it, okay? And I think what was really important was they came to it again in this open-hearted, transparent way, and they said, we want to improve your pathway. Yes, there will be a benefit for us out of this, but as a result, people won't have strokes. And as somebody who used to work in a clinical setting with people who've had strokes, that's a very powerful approach to take. And as the steering group became very mature, we've actually got our final steering group on Monday. Those challenges fell away. And so, you know, in this instance, the AHSN, because the joint work agreement was with us, we were almost seen as the honest brokers. And so any wariness from the CCG could be sort of put to one side. But in the next stage, what we're looking at is a follow-up audit next summer, looking back to say, actually, has it been sustained? Was the difference as we'd expect it to be? We would want that relationship to be directly between the CCG and our industry partners. So the AHSN have done their job. We have made the introduction, we've given the space to have those safe conversations, and then we step back and that relationship continues and matures. Clinicians, obviously, really important as well. So very early on, where we engaged them was by talking about patient benefit and value for the patients and also for them as well. Thank you. Engage early and often. Get people in. We talked to clinicians about the models earlier on. We engaged with, as I say, we as an AHSN, we paid for some clinical time from our clinical leads. They were the face of the project. And I say, if you can get 2 clinical champions, even better. They can cover more ground, okay? Wherever possible, co-design. So they sat in our steering groups. When we designed the materials, if they went, we don't like that, GPs won't use that, they won't even, that's too long, we made those changes there and then. And because we could be very agile in how we did things, that worked. It was a challenge in terms of the sign-off process, working with, I think it's fair to say that both Bayer and ourselves learned a lot about how that worked. But actually, we managed to solve it. And so we were getting materials turned around very quickly within the timescales of the project. And it didn't slow us up too much, I think it's fair to say. Oops, managed to turn that off. Okay, commissioners, all right, really important in terms of finance. Obviously, there's a lot of concern about what it would cost. And what we did is we solved this by having a managerial lead in post. So they were our link into the culture in the commissioning body. They sat in our steering group. They said, actually, you need to slant it like this. You need to say things in a particular way. This is how it might work. Again, consulting widely and repeatedly was important. We made the health economic case from the outset. So essentially it was clear, yes, in year, you're looking at probably more expenditure, but in 3 years' time, you're looking at your strokes really reducing with all the impact that goes with that. And because we embedded the project in the CCG, it was their project, although we ran it, it meant that those antibodies weren't sort of generated and actually it became acceptable. And then industry as well. Transparency, open-heartedness, that was the most important thing from our perspective. Membership on the steering group. We actually had a subgroup as well, which was just the industry bodies, industry partners rather, with our public representatives, so they could have, almost before the steering group, have those conversations about what's in it for you, what, you know, we don't trust all this sort of stuff. And so those conversations were had, and so then it was brought into the steering group environment. The patient representatives were advocates, actually, which was unbelievably powerful. Industry, willingness to try new things. Okay, we want to do this. Okay, let's see how we can make it work within the framework, obviously a very clear legal framework, but essentially it was that willingness to try, to be different. And from our perspective, it was about being aware of industry partners' constraints. Like I say, we were a bunch of pirates, but we learned how to become members of the Royal Navy by working with industry colleagues. That's it. Thank you.
Thanks very much. You mentioned having a plan and making sure that you've tested it with everybody at all levels.
Yep.
Haven't you got to start though with some kind of vision?
I think the vision was clear. So it was, when we started off, it was about reducing strokes, and the way we were going to do that, the mechanism, was by optimising anticoagulation. So we started with that view in mind, and then it was, okay, let's think about how we might get there. And at every point we made, we knew that trying to have this very well set out plan wasn't going to work. I come from a NHS background, so I've worked as a general manager as well, and I know full well that you might have a 12-month project plan. By the time you get halfway through it, it's not worth the paper it's written on, is it really, or the Excel sheet it's on. So I think having a vision is important, but also having that willingness to be able to modify and change your approach as you go.
Right. But I think the fascinating thing was, we've heard industry say how complex it is to get joint working together, and you talking about talking to patients and so on directly, and so you just flip it. So you become the lead and the industry joins in with you.
Yeah,
absolutely. That was rather clever, actually. So you actually got to talk to patients in their home, the real world,
yes,
not in some artificial across table in a conference room or in a surgery.
Yeah, so because we were working with innovative practices in the first phase, and they came forward. We just sent a challenge out to essentially all of our practices across the West of England and said, who's interested in working with us? We actually had more than that who said they wanted to work, but we could only manage 11, a very small project group. And what we said was, and also have you got some patients that would like to talk to us? And they said, yeah. So essentially we worked with the GP. They said, yeah, that's fine. We talked to the patient. Obviously we had the appropriate governance behind that in terms of IG, but we just went out and spoke to people. I think there's a lot of, you can be as technical as you like, but sometimes that human touch could be far more impactful.
Is this all under the umbrella of the National Institute of Health Research? Is that part of what
Yeah, there's sort of like
I think,
AHSNs and all those things like the CLARCs, the Collaborative for Leadership in Applied Health Research and Care. I think we're a part of a bold experiment from NHS England, really. So let's give it a try. And so I think every AHSN has got a slightly different relationship with it. We've got a very close relationship with our CLARC anyway, but because ours was very much about, it wasn't a research piece, it was how do you take an innovation that's known
and make it work.
I
mean, that was the point we heard from a friend there about the health collaboratives. We're going to hear about that shortly, but that's the thing where you've got a ready-made system that you can slot into, which is much easier than starting from scratch. So do you see a day when we can stop using rat poison and get onto some of the decent drugs we've now got?
What a question. I think we can look forward to a day when anticoagulation is optimised. Let's say that.
I'd give a popular science lecture called Pills from Plants, and I always get to warfarin and the Walter alumni are in, and the horses going into massive bleeding from every orifice and dying because the coumarin was being prepared in the clover and all that sort of stuff. And then having to monitor people, looking at their genetic variation. And as people say, do you mean there's something else than warfarin? Because nobody in the health service in England, few of them have been telling them there's alternatives because it costs money.
I think the thing is you need to recognise there are different drivers why people want to use warfarin in the first place. So some patients actually, that's their social contacts. They even know...
Because they have to go and get their monitors.
So although people say, they might say, actually this is clinically possibly more beneficial for you, people choose... We had people that chose to stay on antiplatelet therapy. That's as long as you are able to have that shared conversation.
I mean, I'm not saying the rivaroxabans are without risk and bleeds and so on, but wow, very different. Science has advanced since the Walter alumni. Rick?
Yeah, no, thanks for that. It was really interesting and very interesting that the NHS has taken sort of the lead, as Trevor outlined. Sort of question for me, I suppose, is there was a lot of buy-in here from lots of differing stakeholders. And clearly the greatest incentive is that of patient benefit and reduced number of strokes. Yeah. But did you introduce other levers or incentives against some of the stakeholders that were involved here, or not really? Was the single large incentive of patient benefit clearly sufficient for this project to be as successful as it was?
Gloucester CCG, what they did was they actually introduced it as part of their primary care offer, okay, which essentially is almost like not aware of the details, but it's almost like a quality premium, which practice can choose to be involved with or not be involved with. Because the way our project was, the timelines, the way it worked, so they put their primary care offer together very early in the year, in terms of the financial year, and it was very generic. By the time our project became mature enough to actually do anything with, that was already written up, if you like. And so what that meant was that practices didn't have to be, it's almost, if they could show they'd done something around optimising anticoagulation, they didn't have to take part in the project at all. The fact that even, because that was already there for them, that we managed to get that, actually more than 51, it's, I say almost 60 practices that signed up, for the project, means that wasn't, I think it was there, but it wasn't a sufficient lever. I think it was very much about the clinical lead having those direct conversations, and the clinical lead was somebody that was charismatic, was committed, and spoke passionately. He's the one that came up with "Don't wait to anticoagulate" as a title. Okay, and I think that was.
You
the
do
thing.
need that. You need some.
You absolutely do.
lead it,
Sounds like we're back to people again.
Well, it is. Yeah. Can we go back to that slide where you said the next steps? Is that it? Where? Yeah.
Yep.
So, again, thinking of Wales, we've seen several examples today of where we might take those exemplars and apply them more widely. Again, like we've seen with the epilepsy, it's all this written up somewhere.
Oh, yeah.
Can we get that as a...
Yeah,
copy?
so the actually the slide's gone there, but the website, you can Google it, don'twaittoanticoagulate.com .org, whatever it is.
Yeah.
All the materials are on there, so in terms of both clinical materials and also the quality improvement
we can
materials.
point colleagues
Absolutely,
to
yeah.
that website. Yes, please.
Hello, I just want to say I caught up with you briefly earlier. In Wales, particularly in South Wales, there are a number of projects and pilots looking at this. I mean, in Cardiff, for example, in Cardiff and Vale, all GP practices are signed up for enhanced service level agreements, so they can all initiate anticoagulation therapy, and they get good support and advice from the tertiary centre in terms of offering patients choice, but also informed choice about what would be the best option for them. And of course, each of those options has different implications. In other parts of South Wales, other health board areas, you know, that there have been barriers because of various issues, you know, LMC negotiations, etc. So I think there are good examples out there, but I think a project like this, and what we'd be looking for is the network, really, working with our colleagues in the stroke implementation group, is to act as umbrella organisations so that we can work at a level above the health boards and support and facilitate this sort of work.
It's a similar model to the ABPI, isn't it, really, in terms of that? It's acting as that hub.
Absolutely.
That can promote that
yeah,
innovation
really good
partnership.
stuff. Thank you.
So let's put that together and see what we can do. Okay, thank you very much indeed. That was very, very useful.